We have Dr. Charlie Berul here with us today, and he's going to be answering some of the questions you've submitted through Facebook or through our family support chats. Dr. Berul, would you like to introduce yourself?
Sure, thanks for inviting me. I'm Charlie Berul. I'm the Chief of Cardiology at Children's National Hospital in Washington, D.C. I've been a SADS member since I was a fellow about 30 years ago. So since the early inception of SADS, I've been actively involved for many years.
Thank you. We appreciate all that you do for SADS and for our families. So some of the questions that have been submitted, the first one is, what can I take for a cold or a cough with SADS?
Yeah, that's always that is a common question that we get a lot. And I can give my opinion from any of these answers. May not be the exact medical answer, but at least my opinion. The issue with colds and coughs are nothing is a cure. So whether you have a SADS condition or not, the medications that you take basically aren't going to cure you of your cough or cold. They're just going to provide symptomatic relief. And so you don't want to make things worse by taking something like that. So the main things to avoid are the decongestants. So anything that has a D at the end, I would try to avoid. But I think it's fine to take some of the common non-sedating antihistamines, things like loratadine, brand name Claritin, or Allegra would be okay without the D in it. The ones that are just the plain non-sedating antihistamine should be fine in normal doses.
Great, thank you. And then what about dental care with SADS conditions?
Well, dental care, I guess there's two issues. One is if you have a structurally normal heart, then you don't need the antibiotic prophylaxis that is sometimes recommended for people with structural valve problems, congenital heart diseases, and things like that. So it's more the issue of whether it's safe to have the epinephrine in the numbing medication. So lidocaine with epinephrine, and the dentists use the one with epinephrine to have the lidocaine act locally because it constricts the blood vessels and it allows the numbing to be just in the mouth rather than going through the whole body. And so there's advantages of having the epinephrine in the numbing medicine. And so for those reasons, in general, I think small amounts of numbing medicine with the epinephrine are reasonable. It's not going to get to levels that would impact the heart. Just don't have the dentist overdo it. If they think they have to give a lot of numbing medicine, then they should probably use the one without epinephrine in it.
Thank you. After a parent has been diagnosed with ARVC, does a child have to wait to be a certain age or to develop symptoms of ARVC before they receive genetic testing?
Oh, that's a good question. So the child, I think, you might want to wait to do more clinical diagnostic testing that may be more may show up as kids get older. The gene's going to be there right away. So if they're a carrier of the gene, that can be detected at any age, even in infancy, although what you do with that information may differ based on age. So with ARVC, for example, it may not develop any what we call phenotype or anything that you can see by imaging or rhythm abnormalities until they're older children. But the advantage of knowing early, especially if they're gene negative, if the parent's gene positive for the disease-causing mutation and the child doesn't have it, then you can discharge them from cardiology and there's no extra worries about them. So that would be the advantage of doing it early, is to find a negative test. If you find a positive gene test in the child, as long as it doesn't add extra stress on the family knowing the child has it, that's really the main disadvantage of knowing early. But maybe steering them away from very vigorous competitive athletics so that they don't get disappointed when they're teenagers and can't play varsity football. If you steer them towards other activities early, that would be the other potential reason for knowing early.
Thank you. So many of our families have teenagers in their homes with SADS conditions. How can you help teenagers be adherent to their treatment plan and taking their medications?
Yeah, as a whole, teenagers are notoriously not so great at taking medications. And it's even harder for conditions like some of the SADS conditions that don't have any symptoms. And so they're like, well, what do I need to take a medicine for if I feel fine? And so if you have long QT syndrome, just to pick one of the SADS conditions, and you feel fine, why do you need to take a beta blocker? That's, it's sort of teenage thinking and the invincibility of being a teenager. And so I think you need to have them really buy into it early and understand early the importance of taking their medications on a regular basis, and not missing doses, not taking it sporadically, is really important to have them understand the rationale for treating something even when they feel fine.
Some of our families have problems with side effects from their medications. How and when should a patient bring up those side effects from their beta blockers, such as fatigue, depression, etc.?
Yes, the side effects are the biggest issue with beta blockers in particular, and they should bring it up as soon as they recognize it, or as soon as the parent recognizes it. I think it's common in the first week or so, so I wouldn't worry so much about it in the first week of taking a beta blocker. But if they're noticing it and it's lasting more than a week, they should definitely bring it up with their caretaker, with their physician or other caretakers, because there are other options, either different beta blockers. Some people have a different reaction to different beta blockers. That the side effect profile might be different. There is the left sympathetic denervation that can be utilized if sort of a surgical beta blocker, if the taking medication every day is too much, causes too much of a serious side effect, particularly depression, which can be life-changing.
Okay. And how do you encourage your families that you see in your clinic to live with their SADS condition?
That's a sort of a general kind of question. And I think to live with the SADS condition is like any other condition. Do as much as you can do. You may have some specific limitations that your own physician and caretaker advises for you. The concept of shared decision making is a big issue that's over the past, really over less than a decade, probably five to 10 years, of involving the patient and the family in the decision making for how much they can and I never say can't do, but maybe shouldn't do, is really a shared decision in terms of understanding the risks of specific activities, competitive athletics being the biggest one. Unsupervised swimming is probably not a great idea, but supervised, they should be involved in doing as much as they feel comfortable doing, and for children as much as their family feels comfortable in allowing them to do. We don't want them to be couch potatoes, because that has negative consequences as well, both physically and emotionally.
Thank you. How do our SADS families know that they're getting appropriate care for their conditions?
Well, I guess that's a good job for the SADS Foundation to refer to experts in the areas, and there are many experts in SADS conditions throughout the country and throughout the world, and connecting with them via the SADS Foundation can refer and give recommendations for who are the experts in the regions that you live, to make sure you are getting appropriate diagnosis, appropriate treatment, and appropriate recommendations. One of the things that I see, I want to just add to that, sometimes patients get overdiagnosed, and we've seen that over and over again. Sometimes even you come in and the parent has a fresh implantable defibrillator that was just placed by someone, and then you're asked to see their children, and you might not agree with the recommendation to have placed the defibrillator immediately in the parent, and maybe they don't even have the the diagnosis. So I would encourage people to make sure that the diagnosis is correct and that the treatment recommendation is correct.
So for that, if they have seen a physician that maybe isn't an expert in that field and they've been given diagnosis, would you recommend a second opinion by an expert?
Absolutely. There's really no harm in getting a second opinion, and you can always, it's reassuring to the family if there's concurrence, meaning if the opinions are the same, and if the opinions differ, then the family has to consider what's the best recommendation from those providers.
Thank you very much for answering all of those questions. Do you have any additional comments or thoughts that you would provide for our families?
I think being involved with the SADS Foundation is a great first step. So I'm already talking to a group that's involved with the SADS Foundation if they're watching this. So that's great. You've taken an important step. I think having a dialogue with your care team and making sure that you're on the same page, that your physician and nurses that take care of you are in agreement with what you're doing in your daily lives and your medication, and potentially if you have a device, the routine in terms of monitoring for that. And other than that, and connecting with other families to see how they're doing, which is another good resource.
That's great. Thank you so much for your time today, Dr. Berul.
My pleasure. Nice talking with you.